we could get started. Again, I'm Jill Rockbeisel, the chair of the department, and I want to welcome everyone, departmental faculty, staff, our invited guests, friends, colleagues, to our Grand Round series. And looking very much forward to the Taghi Moderessi lecture, which we have every year in such honor of him. I just ask people to remain muted. And I'm assuming, Kay, you'll manage questions kind of at the end. And I hope that you enjoy the presentation. Kay, let me hand it over to you.
Thank you so much, Dr. Rockbeisel. I am so excited to be here today with everyone. This is our 25th annual memorial lecture honoring Dr. Taghi Moderessi, who was the founder of our center in 1982. So our center very much does the same things that Dr. Moderessi envisioned and put into place back then. We gather our community for symposiums, for trainings, for learning from experts in the field, inventors, pioneers, people that are really moving the field forward. And we're very lucky to have Dr. Gross here today, who's one of those folks. Just a little bit more about Dr. Moderessi. He, in addition to a commitment to training, was also a psychoanalyst and committed to clinical care. And my colleague, Bree Fellows, clinical social worker, clinical program director, leads that effort for our team today. And we're very proud of the clinical work that we do both here on campus, but also in primary care settings and early care and education settings. And also research is an important part of the mission, and we participate in research activities too. And if you're able to stay on a little bit longer today and attend our board meeting, we can kind of catch you up on the things that we've done in particular in the last year. So Dr. Moderessi was a well-known child psychiatrist and professor here on campus, and he worked along with my colleague Carol Norris-Shortle, who's here today, to develop this robust program, an innovative program. We and the Reginald Laurie Center in Montgomery County are really one of the two centers in our state that primarily focus on mental health services of young children. And we train professionals and we train the workforce throughout our state. We are very privileged to get to introduce you to Dr. Deborah Gross today. She is the 25th invited speaker for the lecture series, and she is our first nurse. So apropos of good mental health care, which is interprofessional and interdisciplinary, we are very proud to introduce you to Dr. Debbie Gross today. We as a team have learned a great deal from her, and that's why we wanted her to be here for you to have that chance today to learn from her as well. Dr. Sarah Edwards and our team are part of a multi-site study that Dr. Gross has underway, and she might be talking a little bit about that today. And also our team members, including Shanique Rogers Henry, who is really our champion for the model that's going to be discussed today, is really integral to the care that we provide in our center. Dr. Gross has really a remarkable CV, and she has 3 appointments at the Johns Hopkins in nursing, public health, and psychiatry, as well as other research appointments. So you can learn more about her work and through her CV. So this is a wonderful community-based project, but it has a lot of rich research behind it as well. So we hope that you enjoy the talk today. I will monitor the chat, and we'll have some time at the end for questions too. Dr. Gross.
Thank you so much, Kay. This was such an honor. So thank you all for being here. So, all right, did it progress? The
Yes.
slide? Oh, thank goodness. Okay, so I have a quick disclosure to make. I am the developer of the Chicago Parent Program. We are able to receive revenue from the program. I do not take any income from it, but we do use the revenue to continue to improve the program. So, and I also have to have some other, I am so grateful to so many collaborators. I'm going to be talking about the development of the program and research, but none of that can happen without some amazing colleagues and amazing students. I also couldn't have done it without some amazing funders. And I am very lucky to have funders who not only support the work financially, but they also share their wisdom and insight with me. And that's also helped to make the program better. And I'm grateful to everyone. So I want to give a little bit, so set the stage for what I'm going to be talking about. And some of you already may know this, but the top 5 chronic health conditions in children in the United States today are all social, emotional, developmental, and behavioral. Asthma is number 6. And so I think that it's really important to sort of understand the context in which we're dealing with children's well-being in the United States. And the other important part about it is that all of these problems are more than twice as likely to happen, occur among children who are living in poverty. Well, I want to talk a little bit about poverty. Means poverty is not just not having enough money. Poverty also means that children are going to be much more likely to be exposed to much more adversity, adversity within their family, such as physical abuse, emotional abuse, domestic violence, and in their communities, such as witnessing violence and discrimination. And not surprisingly, being exposed to a lot of these ACEs creates behavioral health problems for the children and makes it much harder for children to learn. And the other important part about this is that when we're working with children who are growing up in low-income communities, we're often working with families with multiple generations of adversity and poverty. So there was a study done by Chetty and Hendren a few years ago where they looked at the cities in the United States with the largest 100 cities in the US, and the odds of moving out, being born into high poverty communities and moving out of those communities. Baltimore ranked 100. It was among the lowest odds of children growing up and moving out of poverty. So we are dealing, as I said, with families with multiple generations of trauma and adversity. Now, what you call this really matters. If you call this an achievement gap, your solutions are going to be focusing on education policies, your teaching workforce, benchmark testing, and early childhood enrichment. But if you call this a risk gap, which is what this is, your solutions are much more likely to focus on urban policies, mental health, trauma-informed services, supporting families, and addressing resources of racial and economic inequities. So I think we have to really think about what the languages that we use and how that really sets us up for thinking about policy-related solutions. So now I'm going to talk about parents and the power of parents. So I am a child psychiatric nurse, as Kay mentioned, but I learned long ago that you cannot help children without helping parents. Parents are the constant in children, and I'm talking about parents more broadly and other adults caring for children, including grandparents and foster parents and all, just a range of family and non-family that are engaged in raising children today. But you cannot help children unless you help the adults, the parents who are supporting them, because if the parents are struggling, the children are struggling. And as Jack Shonkoff said, and Jack, for those of you who probably know, a brilliant scientist at Harvard at the Center for Developing Children, who really changed the way we think about toxic stress in families. He said early on, the health and well-being of young children is inextricably tied to the health and well-being of the adults who care for them. This is a very true statement. And then Irma Bombeck, who's not a brilliant scientist, but also said something brilliant, which is parenting is the world's largest on-the-job training program. And that is also so true, that for all that we charge parents with, the responsibilities, the important work that they do, we give them so little support, so little help on knowing and feeling confident in what they're doing. But parents are incredibly powerful in this whole operation. So, when we look at the research on children who have grown up under fairly harsh conditions, it consistently shows that children who have had a safe, stable, and nurturing parenting relationship, that this has been one of the most powerful buffers against adversity for children, that these are the children who tend to fare well. And the really good news out of all this, of all of the things that we know affect children's mental health and well-being, most are difficult, if not impossible, to change. Parenting's not that. Parenting is very modifiable. We have a lot of evidence that you can change parenting. So this is I'm now going to talk about leads us into the Chicago Parent Program. So in 2002, when I was living in Chicago, we designed a program called the Chicago Parent Program, which if I ever thought I was going to be leaving Chicago, I probably wouldn't have named it this, but at the time I thought, oh, we're just going to, build it here and I'm not going to go anywhere. But we developed a program called the Chicago Parent Program, and we designed it to specifically address the needs of families raising young children in low income and underserved communities. And this was really because so much of what was out there for parenting was really, really based on white middle income two-parent families. And I really wanted to develop a program that strengthened parenting skills and confidence in parent-child relationships, that promoted children's social, emotional, and behavioral well-being, but that would really address the needs of families raised, because it's not a level playing field. They have different needs and it's a different context. And I wanted to make sure that whatever program we developed would be meaningful and relevant for families. It focused on parents of initially 2 to 5-year-olds. It's expanded to 2 to 8-year-olds. And it has a trauma-informed approach, which means that it's designed to have a very safe, non-judgmental space for parents to identify their goals for their children and tailor the strategies for achieving their goals. So parents are always in the position of deciding how they use the program. So it's a 12-session group-based program. We use multiple strategies for supporting learning. We have video vignettes and group discussion and problem solving, because we want to stimulate all the senses in learning. And videos and watching somebody else, do something well and not so well is really very helpful for going, oh, now I get it. But then we have these guided group discussions, and I'm going to give you some examples of how that works. We also have in-session practice and group activities so that parents can try out some strategies with other parents. And then there's weekly take-home practice assignments where parents then practice the skills with their child. And then there's these brief, simple handouts that we give out every week. It's led by 2 trained group leaders, and the program is available in Spanish and in English. The Chicago Parent Program is guided by 2 theories. One is attachment theory, which is the importance of having a safe, stable, and nurturing caregiver. The other is something called the coercive process model, or social learning theory, which, in short, basically parents inadvertently reinforce all the wrong behaviors of what they want in their children. And it's just such a natural thing that we do. So just at a very simple level, we tend to, say very little when our kids, do what we've asked them to do, when they play nicely with their siblings, when they share their toys, and we say an enormous amount to give a lot of attention when they don't do what we've asked, when they when they're fighting with their siblings. And so what we're really trying to get as parents to do is the exact opposite, which sounds a lot easier than it is to do. This is the overall curriculum. The first 4 weeks of the program really center on helping parents to clarify their values and their goals for their children. And then it's around building and strengthening a positive relationship with their children. And the second 4 weeks are now focused on setting clear and effective limits and following through on those limits. The third unit, which is another 2 weeks, really focused on stress, reducing stress and problem solving skills. The stress reduction program, actually, you mentioned Shanique. Shanique and her colleague Michelle Daniels were just hugely helpful to us in further developing the stress management session. We included much more on mindfulness strategies. We have some cognitive reframing strategies and affirmations. And then the problem solving one is on really how do you apply problem solving skills in talking to co-parents or with children. And then the last 2 weeks are really on sort of synthesizing all of what the parents have learned and then having a celebration for all that they've achieved. So what makes this program different? Is a few things. First, it was designed in collaboration with parents. And there are about 130 vignettes in the program. Over 75% are families of color. These vignettes, they include families from Baltimore and Chicago. Who let us shadow them with a camera for a half a day. These weren't actors. These were parents in their homes, stuck in a laundromat for 2 hours with their kids, crying and, bored out of their minds and fighting with their siblings. And because the advisory group said, when I was working with them, they said, I want to see kids who are, parents managing situations in public. And so we made sure we had that. And I worked with this advisory board for about 8 months in designing this program, which I'm going to talk a little bit about too. It shows the real parents managing real situations at home and in the public. Chicago parent program groups can be led by paraprofessionals. We're one of the few programs in the country in which you only need a high school diploma in order to go through the training. But it's still a very high level skill, but most of it is about really understanding the community and being able to engage parents in the community. It's very parent-centered. When we train group leaders, the main thing that we want them to understand from the first hour of training is parents are the experts about their children. We are not experts about their children. No one else can know what's important for their children. And so parents are in the driver's seat the whole way, deciding what their goals and values are for their children and what strategies they want to use and not use, or how they want to tailor the strategies. But all of the strategies that we describe in the program were framed to enhance relevance. And I did this with the advisory board. And I'll give you some examples of this. Praise is one of those strategies that most parenting programs talk about. Praising children for, doing things well, using labeled praise. Well, the advisory board said to me, we don't praise our kids. Praise spoils kids. It creates entitled children. And frankly, they're not entirely wrong on that. They said that no one praised them. And they said, and this is really important, my job is to toughen my child for a world that will never praise them. And that's very important to understand. And so what we build into the program is this, and I talked about this in the advisory board with them too. 10 years from now, it starts off in this, by the way, in the third session, 10 years from now, how do you want your child to feel deep down inside about themselves? And the group leader, and they offer the group to ask, think about it for you, those of you who have children, how do you want your child to feel deep down inside? And some of the adjectives are very universal. I want them to feel confident. I want them to feel loved. I want them to feel strong, respected, independent. And now the question is, what are the behaviors you're going to see now when they're 4 that's going to help them to develop that core sense of self? Because if you don't give your attention to those behaviors now, how are they going to develop that core sense of self? And that changes the conversation with parents. Parents often will, no one's ever asked them what they value. No one's ever asked them what their goals are for their kids and how they want them to feel inside. And I think just that awareness of them saying, yes, I want them to have that core strength. And yes, I need to how do I give my attention to those things that are going to build that core sense of self, and not to the small minutia that we tend to think of when you think about praising kids. The other thing we talked about was spanking. They were very clear with me that they would never come to a program that said no spanking, or they just wouldn't say what was really going on. They said, I was spanked and I'm fine. They don't think timeouts work. The kids don't really care about them. And if I went to a program that said no spanking, I just wouldn't say what I was really doing. And so I asked the parents in the room in our advisory board, how many of you in here were spanked as kids? And if I were in the room with you now, I would have you do the same thing. How many of you were spanked as kids? And everybody in the room raised their hand. And then I said, how many of you in here were spanked as kids and still felt loved? And half the hands went down and half stayed up. And I said, to those of you with your hands still raised, how did you know you were loved? And they said things like, well, I knew when I did that, I was going to get spanked. She told me she loved me. She was whooping me. When it was over, it was over. And out of that conversation came what we developed into the program, which is we teach the 8 keys to effective discipline, which means that regardless of the discipline strategy you're going to use, it's got to be tied to a specific behavior. It's got to be safe and age appropriate. It has to be predictable. It has to be controlled without rage, without humiliation. It has to have a positive ending. And children have to know they are loved, even though the misbehavior is not loved. And those 8 keys have been very, very helpful because frankly, you can yell at your child in a really damaging way and never lay a hand on them. And so I think we get very caught up in spanking. And now we don't advocate spanking, but we don't get caught up in the conversation about spanking. It's really whatever discipline strategy you use, it's got to be tied to these 8 keys. So now I'm going to give you an example of some of the how the videos work. This is a video that is shown in the session 2, which is on routines and traditions, is preceded in session 1 by child-centered time, which includes following the child's lead, which is a very common strategy. It doesn't have to be during play. It can be, because a lot of our parents also said, they do not like that a program says you've got to play with your child. They said, that's what you do when you have leisure time. I don't have leisure time. And so we reframed as child-centered time could be done, cooking in the kitchen, during bath time, in the grocery store. Anyway, this is around reading. And we also say to parents, read to your child, but a lot of parents who've never been read to don't necessarily know what that should look like. So with that in mind, I'm going to.
Kevin, you can read too. Who's that? Bella. Tripped and fell. I lost my glasses. Yeah, she lost them. Ooh, what's that? Is that a ghost? No, it's the cat. Scooby-Doo looked under the yeah. Scooby-Doo found a spider under the bed. Are you scared of spiders? No. Yeah, right. Now you see it? Yeah, you see the spider, you go. Remy did not find Velma. Oh, look at the spread there. Good food, isn't it? Kevin, what do you like on that table? You like a sandwich?
I like all of them.
You like all of them? Yeah, you probably do.
Okay, so at the end of this video, the group leader will ask things like, well, first of all, how did you know this was a routine? What did you notice? And then might ask, like, how did this parent make this reading session child-centered? What did she do? And how do you think the children are feeling? How do you think the children are feeling about reading? So the idea is that the videos are really to stimulate discussion and helping parents to see sometimes what is going well in the video, and some of the ideas about what it makes a child-centered, what makes the reading child-centered. But not all of our videos are of parents doing things great. Here's another example.
John says you gotta leave your toys. You can take your books, but you leave your toys. Okay? You can take it in the car then, okay?
Okay, what did she just learn? And this is I should have preluded this by saying this is a video that we show in the 5th session. We talk about the importance of setting limits, so being clear, but then following through if you've set a limit. And this is about a 9-second video. This gets so much discussion about, what happens when you're trying to get a child out the door? And you don't want them to have it, to fall apart. They got to get out the door. The parents got to get to work. She's got to get to the daycare center. And it's a really good discussion about how do you manage these situations? How do you anticipate them? Or once you realize you've fallen into a trap, how to back out of it. Anyway, that's the idea behind some of these videos. One last one. This is from the session on, one of the principles of the program that we talk about is if you want to see behavior, give it your attention. But if you don't want to see behavior, try not to give it so much of your attention. And that's the idea behind the coercive process model. This is a video from the session on ignore. And I think it's session 7. And parents, just going back to my original point, parents decide what is ignorable and what's not ignorable. And they make a list, very early on in the beginning of this session. So what do you think is ignorable and what's not ignorable? And parents all differ on this. But tantrums are one of those things that most parents think can be ignored. But ignoring probably won't work. So anyway, here's an example.
Debbie, this one we can't hear.
Oh. Let's see. It's up there. Well, he's screaming. That's all you need to know. He's screaming very loudly. And now he has stopped screaming. And by the way, none of these are actors, and you can't get kids to do that. And it's just a really interesting conversation in the group where parents going, I didn't think you could do that. Another parent might say, I can't let that happen in public. Somebody is going to report me. Somebody's going to and another parent would say, because I've seen this, you just tell them I got this. And so the other aspect of the group is really that exchange, that support that parents give to one another. Because I could say to a parent, you can ignore it, and they'll just look at me like you have no idea. But another parent from their community who goes through the same thing will say, you can tell them you got this. That comes out very differently. We've had parents say, I tried a strategy because another parent said it worked. Okay. So now I'm going to talk a little bit about the research. We did we did 2 in Chicago, 2 validation RCTs. And in this one, we did it in childcare centers that were subsidized for low-income families. Over 500 families, most of them were mothers, but we had some fathers and grandparents. Most were African-American, Black, or Latino, and most were single-headed households and reported very low incomes. What we found in these randomized trials was that relative to controls, parents in the Chicago Parent Program reported significantly greater self-efficacy. And this is important for a program that never says no spanking. We got significant drops in parents' use of corporal punishment. And parents also use more consistent discipline, and they demonstrated more positive parenting behaviors during observations, parent-child observations. We also found greater drops in children's behavior problems based on parent report, teacher report, and independent observations. And these were effects that were sustained up to a year. So then I moved to Baltimore in 2008, which was a wonderful move. I love Baltimore. And I'm at Hopkins. But I made some really great colleagues and friends here. And one of them was Harlan Belcher, Dr. Harlan Belcher at Hopkins. We got a grant to do a pragmatic non-inferiority trial comparing the cost effectiveness of Chicago Parent Program with parent-child interaction therapy. And so we'd already had evidence that it was effective in a prevention in the community as a prevention intervention. But we were now testing it for treatment, and we were going to test it against what's often considered to be a gold standard PCIT, or parent-child interaction therapy. And we did this at Kennedy Krieger in a clinic that focuses on families and children who've been exposed to traumatic stress. The primary outcomes were treatment engagement, children's behavior problems, and treatment cost. So you're probably, most of you, familiar with PCIT, but just to make it clear, these are two interventions with the same theory, same content, same treatment goals, and just very different delivery models. And so you can see on the left, PCIT, there is a therapist that coaches a parent from behind a one-way mirror. The parent wears a microphone in their ear, and it's mastery attainment, so mastery based. So a parent learns the first skill and does not learn the second skill until they've mastered the first skill. So the program progresses at the rate with which parents will master each of the skills. Extremely powerful program, very strong outcomes. Chicago Parent Program is a 12-session program. If you miss a session, you know, wouldn't be makeup sessions, but it's in a group, uses the video. Parents are very much in control of what they learn and what they use. So just a little bit like, what does all of this mean? So if randomized means that, you know, parents were approached for consent after completing the intake and diagnostic evaluation, and then they were randomized to the conditions in blocks of 10 because we needed 10 parents to form a group. It's called non-inferiority because we're creating a sample power to detect no statistical significance between the two groups, or no clinically significant difference. And as mentioned, you're often doing these pragmatic trials or non-inferiority trials to compare a new intervention against a gold standard. And it's called a pragmatic trial. And what that means is you're testing an intervention under normal practice conditions to inform practice. You have very few exclusion criteria, and you have no added resources. So we didn't have this done by graduate students. It was all done by practitioners in the clinics employed through the normal process that they use. And I have to say, I've told people this, I've done a lot of research in my life. This was the hardest study I ever had to do because I had no control over what was going on. And it was my eyes open to mental health practice and just what the constraints are in mental health practice. This is the sample. In part, I'm showing you that there are no differences between the CPP and PCIT groups, but also to show you that the population looked very much like our populations in Chicago. They were primarily African-American. They most had a high school diploma or less. They had very low incomes. Nearly all of the families were insured by Medicaid. One of the things on the fourth line, the CESD baseline, CESD is a measure of depressive symptoms, and there is a score of 15 that's typically used as a cutoff for clinically significant depression. So above the 15 or higher is typically indicative of depression. You see, the means of these two groups are over that cutoff of 15. So there's quite a bit of depressive symptomatology going on in this population of parents. About half and half boys and girls, about 3.5 years old, and here were the primary diagnoses of the children. So I'm going to talk a little bit about the results because I know a lot of you are actually working in mental health treatment centers, and so this might have real relevance, especially for you guys. We looked at the percentage of parents who never attended treatment, and and over a third never attended treatment. And I think a great deal of this is related to how long it takes from the time that a parent calls and says, I need help, to the time that can actually be with a therapist and get the help. And so many parents give up and maybe go to see their primary care provider and get the medication for their child or do something else. But yeah, I think a lot of it was just tied to how long it took from intake to get to start treatment. The number who completed. Well, most of the parents didn't do the full CPP sessions, and they didn't complete PCIT. There were no differences between the two conditions. But the average number of sessions needed to complete was a lot different. It took about 11 sessions to complete CPP. It took 30 sessions on average, but some up to 52 sessions to complete PCIT. And that some of this is a real testament to the therapists who did not give up on parents. And it also took a lot longer, not surprisingly, to finish treatment. It took 87 days on average to finish CPP. It took over a year on average to complete PCIT. The treatment delay, we actually thought the delay to start treatment would be higher for CPP because you can't start the group until you have a critical mass of parents that are enrolled. Turns out it took longer delay to start PCIT. And I think because the parents were engaged in PCIT longer, so it took longer for a space to open up for a certified PCIT therapist. Satisfaction was high in both conditions, but parents in the CPP condition were much more likely to say they were highly satisfied with treatment. And this is, I think, the other really important finding. Parents who had high levels of depressive symptoms were significantly less likely to drop out of CPP than in PCIT. There were no differences in children got better in both conditions. There were no differences in the improvements in the two conditions for child behavior problems. But the cost was really significant. It cost about 50% less to implement Chicago Parent Program relative to PCIT. Now, that difference got a little less because the therapists often felt strongly about adding individual sessions between groups to check in with parents. I don't know whether this was because parents really needed the individual sessions or the therapist needed to confirm that the parents were okay and felt more comfortable doing that. But just so you know, that added some additional costs, but it was still like a third less, even with this added. So here are the take-home points thus far. Chicago Parent Program was designed with parents to ensure its relevance and diverse across diverse racial and economic backgrounds. And we've been able to demonstrate that strategy was really effective for really strengthening parenting. And we also discovered it was a cost-effective treatment also for children with mental health problems. Question now is, so it works fine in a clinical trial. But can it be scaled in communities outside of Chicago or Baltimore, or even in Baltimore, but scaled outside of a clinical trial? Which brings me to this next project, which has been really a labor of love of many people. Amy Betancourt in particular is very, very, very involved in this study. And the Fund for Educational Excellence, a fabulous community organization that has been our partners in this for a long time. So from 2014 to 2017, we had a number of wonderful Baltimore foundations that funded us to test Chicago Parent Program in Baltimore City Public Schools. The idea was to strengthen parenting and parent-child relationships, promote young children's social, emotional, and behavioral well-being, build parent engagement with schools, focus on schools in high-need communities, but also to understand implementation issues using Chicago Parent Program in Title I public schools. And we focused in this study specifically on children and parents of children in pre-K. We knew from our work and all of the other literature that participation rates is usually a problem in these studies. And so what we instituted was a conditional cash transfer. I'm calling it a conditional cash transfer. Some people are just other financial incentives, but basically, because conditional cash transfers, which have been used in a lot of countries, it uses a behavioral economics framework to encourage, to sort of nudge parents or people towards focusing on prevention rather than waiting for treatment, waiting till things get bad, to really focus the time early on preventing. And anyway, so when parents signed up, they got a bank debit card. And every time they attended the 2-hour Chicago Parent Program group, they got $15 electronically loaded onto their debit cards. And every time they turned in one of their weekly practice assignments, they got another $5 loaded on their debit cards. And this way happened within 48 hours, they got the money loaded on their debit card. And the average amount, the most any parent could make was $230, which really isn't much. But in our society, even parents who have TANF money, only 25% of TANF money goes to cash. Parents are cash poor. They might, even if they have SNAP or they've got Medicaid or they've got even a housing voucher, the cash is so hugely important to parents. And just to talk a little bit about the neighborhoods, and I mentioned that we were in high need neighborhoods. This is to look at the neighborhoods where our CHIP, we called it CHIP, where CHIP schools were located compared to metropolitan areas across the country. You can see much higher homicide rates, much higher poverty rates, much higher teen birth rates, much lower educational attainment rates. So these are really neighborhoods where, in addition to wanting to support parents, we felt really strongly about wanting to help build communities and place-based interventions. So who enrolled? We had 12 participating schools, 372 parents of 380 pre-K kids. Most were mothers, but we had some fathers and grandparents. Most were parents of color. And again, very much like all of our other samples. Here's what's interesting, different, concerning. 40% of the children of parents who enrolled in the program at baseline had behavior problems in the clinical range on the IBER Child Behavior Inventory. That's a very high number of clinically significant behavior problems. And here's what happened afterwards. We did get a significant drop in children's behavior problems, but we really got a big drop in the number of children with clinically significant behavior problems. Parents were very sad. 59% reported that their children's behavior was much better than before. 70% felt that the program really helped them a lot with relationships other than with their child. 69% were much more confident talking to their child's teacher about their child's behavior. And 94% reported that this program made them feel valued by their child's school. And those are all really important because when we want to have outcomes that are so meaningful to schools, not just for parents and children, but meaningful for schools, because schools are really making a big commitment in an intervention like this. All right, so how effective were these conditional cash transfers? Really effective. Enrollment rate was over 67% of eligible families enrolled in the program. I've just never had, I don't think anybody has had an enrollment rate like that in a prevention program. And over 78% of the parents who enrolled attended. And the average attendance was 8 out of 12 sessions. They just didn't come, just to get the money. They came, and we also measured, I didn't put on it, but the group leaders measured quality of parent participation. Groups were also very high. And the parents did rate the financial incentives as being important, and they attended more sessions. But, and this is interesting, when they enrolled in the intervention, when they in Chicago Parent Program in the schools, we asked them to rate with 13 different reasons you might be motivated to enroll in the program. And you had to check off extra money was 2 of them, but learning better ways to manage their child's behavior, learning better ways to communicate with my child, talking with other parents, all of these other reasons parents might actually sign up for a program. Over half said that it was important, but look, when we then had asked them what was the most important, only 2 or 3.5% said that the money was the most important reason for them signing up. This was the most important. Over 95% of the parents said they really, an important reason was they wanted to learn better ways of managing their child's behavior, and they were always looking for ways to be a better parent. And these 2 were the highest rated for the most important reasons that they enrolled. And parents said to us, the money was great, but it wasn't enough to get me to come there if I wasn't getting something out of it. So we are doing a new study now in Baltimore City schools because we wanted to understand the extent to which the Chicago Parent Program helps parents who have been exposed to trauma and adversity. So we really were looking at the prevalence of ACEs among parents who enrolled, and the prevalence of positive childhood experiences among the parents who've enrolled, and whether those were related to the uptake and benefit of the Chicago Parent Program. And again, in this one today, attendance rate has been, again, over 8, an average of 8 out of 12 sessions, or over 70% of the sessions, which again, and it's interesting to me because when you talk about this, the agencies will first say to us, can you reduce the number of sessions? 12 is a lot. Parents are never going to come to 12 sessions. And frankly, they do. So here's our data so far. Really high rates of adversity. Most of the parents have 4 or more ACEs. Very high rates of having been exposed to violence growing up, physical abuse, emotional abuse, household substance use, feeling unsafe in their neighborhoods, feeling discriminated, household mental illness, and sexual abuse. However, they also report a lot of positive childhood experiences. 71% felt safe and protected by an adult in their home, which I think is one of the closest that we have to whether they had attachments. Adults that made them feel safe. And they enjoyed participating in community traditions. They had non-parenting adults who took a genuine interest in them. And so all of these are really important. So we don't want, people are not just the sum total of their ACEs, but so much of what happens for families is there's a lot of positive, and that's what we're trying to do. We're trying to, ACEs are preventable. But these other positive childhood experiences are also something that's extremely important for us to focus in on. So another study that was completed by one of my PhD students, again, while we're doing this current study in Baltimore City schools, she looked at the connectedness that happens among the parents in the group. So when you talk about doing groups, there's a tendency for people to think that the reason you do groups is because it's cost efficient. You get lots of parents at one time. But no, the actual reason you do groups is because there's something therapeutically valued about that group process. And if you're not taking advantage of that, you're missing a huge opportunity. So we define, social connectedness is defined as a sense of belonging and trust one has to other people within their community. And so she measured it with the sense of connectedness they had to the other parents in the group. And at baseline, we asked the parents how many of the other parents who would sign up for the group they knew, and they actually knew very few of the parents that had signed up for the group. But at post-intervention, there were these very high levels of social connected, really high levels of sense of belonging with other parents in the group. And it was consistent with the things that we had heard, like parents telling stories of how they invited other parents to their home for Thanksgiving, about they looked out for each other. They saw each other in the hallways and they gave a big hug. We also found that the level of social connectedness that parents reported was significantly related to the amount of drop in the children's behavior problems. So Corey also did these interviews, and I think these are some of the quotes that I think are just really telling about what happens. You hear the stories of how other people try the strategies taught in CPP, and it makes you want to do it. Another parent said, as a parent, sometimes you feel like you're the only one that's going through a lot of stuff. But when you hear other parents talk about their kids and the stuff they're going through, you know, it don't make you feel alone. So it has really did help me. Another parent said, it just showed me how much the teachers actually care and how how much help I can get from just reaching out and using tools and things that they have at the school. I've been more involved. I actually communicate more, sending the teacher emails and having her contact me if she needs something that needs to be addressed. And finally, another parent said, the CPP facilitators always brought us in, kept us connected, and always helped us relate to each other. So I just want to point out the multiple ways that these group processes really do create a therapeutic environment for families, and especially families who've gone through a lot. So where are we today? Out of the original TRIP study that went on from 2014 to 2017, that we did in partnership with the Fund for Educational Excellence, when the study was over, all of the schools wanted to continue the program, and the Fund for Educational Excellence continues to this day managing it, which is I have to say, as a researcher, is probably what I'm most proud of. I mean, what you want most is to create something that not only helps people, but when the research is over, it can stay in the community and be owned by the community. And so That's been really important to me. And the thing that's really amazing is that it's also being supported by the district, financially supported, and really shout out to Baltimore City Public Schools for their investment in parents. To date, we've trained over 1,000 Chicago Parent Program group leaders nationally. We've updated to the 3rd edition. We've updated the content, enhanced some of the really changed some of the content that we learned from the group leaders as well as from parents about things that we had to add to enhance its relevance. We've provided more guidance and feedback. We used guidance and feedback we had from parents and the group leaders, but we also provide now more implementation guidance. We have an implementation guide because so many agencies across the country are using the program. And we wanted to, it's a step-by-step guide for how do you start from creating a planning budget to how do you have to actually plan in the organization to implement and manage. It can be reimbursed by Medicaid in child mental health settings. That's a huge boost. And it's listed on multiple registries for evidence-based practice. So today what we focus in on is building capacity for scaling. Group-based Chicago Parent Program is now being offered virtually in many places. One of the things we learned from COVID, when the school buildings closed and they still wanted the parents to have access to the program, they pivoted to a virtual Zoom format, and many schools and agencies are still using Zoom. Susie Breitenstein, another one of our colleagues, she's developed Easy Parent, which is a web-based version of the Chicago Parent Program. We're now, as Kay alluded to, we are testing a individualized version of the Chicago Parent Program because we've learned over the years that while there's a lot of benefit from groups, there are a lot of logistical problems with setting up groups that made it very difficult for some agencies to do, or for some parents to attend because they couldn't attend at that time, or or they had other competing needs that they had to attend to. So the individualized version really is designed to be much more accessible to parents. And it builds in, once again, parents identify their goals. And we work specifically around framing and flexing the program to their goals. Amy Betancourt and Brianna Platt at Hopkins are adapting Chicago Parent Program for parents of infants, parents with a high risk for postpartum depression. Sarah Beal at the University of Cincinnati has been funded to adapt Chicago Parent Program for foster families. And another group in Toronto at Sick Kids Hospital in Toronto is adapting Chicago Parent Program for treating pediatric obesity and preventing obesity. So in close, I just want to sort of talk about what I've learned. Scaling is really important. As John List said, you can only change the world at scale. And it's one of the hardest things to do is when you develop something, making it so that it can work in all these different settings and contexts. So here's some of the things that we've learned. You've got to address a felt need in the community. You've got to involve users in its creation and its evolution. You've got to know what's core to your intervention, but also what can be flexed. The core is what makes it work. The flex is saying it needs to fit within the organizations or the community in which it's being used. It's got to be person-centered. It's got to be accessible in low resource settings. We have too many interventions that have been designed and tested in resource-rich environments and do not transfer well, do not translate well into communities or agencies that just are really functioning with a very bare minimum budget. It's got to be replicable, but open to growth. So one of the big things we always are trying to balance is fidelity and what fidelity means. And again, back to what can be flexed. It has to be able to fold into the normal workflow of community organizations. If it doesn't, even if they love it, when the budget gets cut or the workforce cut, it's the first thing to go. If it gets folded into the normal workflow of the organization, it's much more likely to be sustained. And finally, it's got to have sustainable source of funding. And this is probably one of our biggest challenges because in this country, we don't make it easy to fund prevention. You can fund treatment, and we've learned that, but funding prevention has been probably one of the biggest challenges for a lot of our community organizations. And that's it. You want further information, please don't hesitate to email me or visit our website, which is, by the way, undergoing a lot of construction and reorganization, but it's there.
Thank
I'm
you.
gonna- yeah.
There's a lot of hand clapping, silence.
Is there? Oh, good.
Yeah.
Thank you.
Thank you so much, Dr. Gross. And if we could take some time for some very good questions that folks have. Let's see. I do want to note to everybody, I put Dr. Gross's CV in the chat and also the website, so you can easily grab that. So there's a couple questions kind of around referrals and where Chicago Parent is. And in a lot of ways you talked about that, but I guess I would say for our campus colleagues, you can contact Bree Fellows. We are happy to provide this service, both the more individualized one, and if we can get, referrals for group to make that available as well. But I think Dr. Gross's story about Chicago Parent Program still existing in the schools is really remarkable one. And I don't know if you want to talk more about that.
Oh, just how proud I am of that, and how, I think it says a lot about Baltimore. There's a lot said about Baltimore that isn't positive, and yet I just find the people enormously committed and agencies enormously committed to families. So it's been a wonderful opportunity for me. I feel the same way about the schools. That and that's why I made a real point of saying that it's a huge investment for schools who are struggling with so many real issues with their children and families to make an investment in families. And I think that's just got to be said again. I think that the ACE results are sobering. Just how much families and how committed they are to making a better life for their children. I mean, I think that there's a tendency to think that if you offer programs, in the schools or whatever, only the quote unquote healthiest parents show up, whatever that means. The parents who have the least need will show up. But in fact, that's so not true. I think the thing that we're learning is that parents are signing up and coming because they want a different life for their child, because they're so committed to being good parents, and they're concerned about not only their children, but they're concerned about, they're thinking about their future. So I don't know, I can go on and on about just what it's really taught me and how fortunate I am to have had that opportunity to work with families in the schools. In terms of where the program is being used, there, I think even in Baltimore, there's a lot. In addition to University of Maryland at the Center for Infant Studies, Kennedy Krieger also is offering Chicago Parent Program groups. I believe Mount Washington, we've trained is, and then a lot of the schools, but I think some of the schools have been open to allowing parents whose children are not enrolled in the school but live in the community to come in. I think Arundel and some of those other folks, but some of those other places have allowed parents in the community to sign in. You're on mute, Kate.
I just want to also say there's a lot of good shout outs about how wonderful your talk was, and from Joyce Harrison, talking about your relentless passion is part of the success of the model. There's a question about whether parents who have some kind of child welfare involvement are referred to the model and benefit from the model.
Yeah, we have. I know we've had many parents in the schools who've used the Chicago Parent Program groups to meet their parent training requirements, and to my knowledge, everyone has kept their child, been able to keep their child. So it's been that is one area where I really would love to be able to do more. Right now, so probably people, any of you who are on here who have a closer connection with child welfare and the courts, I think it's really made a difference for families, much more so than a program in which it's very didactic. And, the person at the head of the class is the expert.
Emily, who's part of your team, mentioned that she's had parents that were referred by child welfare. And so, well, I don't know if you want to add anything, Emily.
Yeah, Emily, do you want to say something?
Hi. Yeah, no, I wanted to say that we've certainly had parents who've been court ordered to attend the program, or, to attend a program, or who have had like recent incarceration, and in all of those cases have been very engaged. And just on an anecdotal level, I wouldn't say that there's been any, difference in their level of engagement or their experience with the program.
Actually, you bring up a really good point too, that when I say, one of the things that I think is really important about the groups in the schools is that there is a huge mix of strengths. So we don't want groups in which only kids with behavior problems are being, directed there. Or because the whole point of it is to talk about parenting in the most unstigmatized, non-stigmatized way. And I think that's what makes it even more important for families who I've had some contact with the child welfare system, and feeling it to be in a group in which they feel accepted, supported, nurtured, and the issues that they have are not uncommon. So I think all of that is probably one of the reasons, Emily, that it's worked out well for parents who have come court ordered, and maybe none of the other parents know that they're being court ordered.
I've been thinking a lot about attachment theory recently, and you really reminded me that, we're attachment beings too, and we all learn through social relationships. Kids learn when their parents pay attention to something and they have that joint attention together. And I just was thinking about that when you were talking about the benefit of parents learning from each other and getting that kind of not just support, but also the learning and the courage and the confidence to try something.
Yeah, and I think the other thing, and I don't know if I said this loudly enough, it's all about the group leaders. It's all about the Shaniques and the Michelles and because and one of the reasons we don't require that you have a high level, like a PhD, when the very beginning, we had people with PhDs running their groups, and they were kind of terrible, because they didn't know the community. They didn't, and then we have folks who are like from in the Head Start, who know the families, who are very connected with the community, and they're amazing. And some of the feedback I've gotten on how to improve the program have come from group leaders who said, like Connie Phelps, who I don't know if Connie is still part of the Center for Infant Studies, but she was one of our early group leaders. And she was telling me, parents don't, like we were talking about cognitive reframing. We talk about, how reframing. And she said, parents don't get it. It's too complicated. I don't think I realized just how intricate cognitive reframing is. And so, or some other things that, our group leaders would say is, they need more help on this. So anyway, it's the group leaders are so much the secret sauce of making this work.
That's awesome, Dave. So there's two kind of different questions. So put out Dr. Goldberg's, which is post-training, is what kind of post-training consultations offered to their help with implementation or sustainability or fidelity?
We do that. I think Amy Bencourt, I don't know if Amy, if you're on, but Amy has done a lot of consultation with agencies and helping them get started and planning. So yes, absolutely. Very open to doing that.
And then there was another question. I think people really appreciated, how the approach you took to make this program culturally relevant and responsive, and in partnership with communities and families. And so the question is, are there some examples of parenting skills being incorporated into the program that are adapted for families' cultural backgrounds and generated by the participants?
I think that some of that adaptation occurs on the ground within the groups. Again, this is where group leaders are so key in understanding the cultural values and needs of a population. But framing everything in terms of what are your values from the very beginning, what is your goals? What is important to you? What is ignorable? What's not ignorable? What are the things that you want to build inside your child? Every step along the way, we're saying, you decide how to make this work. And so I think that, and I could be misreading this, I'd love to hear from other people, but I don't think we have to make a lot of cultural adaptations, because it's the whole point of it is for every parent to adapt it to what their goals and values and needs are, and what their own families are willing to tolerate. Some of the parents say, I can never get away with that in my family. And so there's a lot of individualism that goes on.
That person-centered approach that you mentioned as
Yes.
key. Yeah. And Dr. Nancy Lever is wondering about whether or not this could go to scale at a state level for all the schools in Maryland.
No pressure.
I would love it. I think that's the goal. And the thing that, going back to the Fund for Educational Excellence, I'd say you need a hub community organization. I think it's hard for the schools to manage because there's so much else going on, and there's so many issues that become crisis issues, that you need an umbrella organization that manages the operations or manages the coordination. This is where the Fund for Educational Excellence, Quan, Wyatt, and Aaron Cunningham have just been so important for managing within the schools. In Cincinnati, the hub is Cincinnati Children's Hospital, and they have a lot of organizations in the community. They are the hub because they have the resources that manage the group leading, and who's going to do what, and make sure everybody's got their handouts, make sure there's fidelity monitoring going on. So my point, Nancy, I think would be, yes, but let's make sure that there's a structure in place to support the schools.
I'm already private chatting, Kay, that CIS could be the hub, and no pressure, Kay.
Let's see. I feel like I'm hoping that I got the oh no, there's yeah, I'm hoping that I got all of the questions, but if someone, before we transition to the next part of our event today, if I didn't, please just come off mute and ask.
I have a question about the tantrum video that you showed. I haven't really worked with kids, but when I was learning DBT, Marshall Linehan talked about like validation and how like when the kid was trying to express their frustration and you don't hear it, you don't respond to it, that can lead to emotion dysregulation, because they feel they just need to go louder and louder to make you hear them. So I wonder, like, what's the rationale for like ignore, and how does that go together with Linehan's theory?
It's a great question, because I think that parents need to have a sense as to whether what's happening is true dysregulation and a need for somebody to come in and help to console and quiet and regulate, or if it's being used for manipulation to get your attention. And we have that conversation. And you do have to have some sensitivity to what's going on. And so I think you bring a good point. We don't want to be so behavioral that it's devoid of context and understanding the child, understanding what's going on around them and what children need. It mostly is to say that there are certain behaviors that the children do to get your attention. And in those situations, if the behavior you don't want them to do to get your attention, don't give your attention. I think that's the difference. But absolutely, we do not want children dysregulated. We don't want children feel that they're left to their own devices to pull themselves together. Does that help?
Yeah, thank you.
Yeah.
And I think that's really true to that attachment perspective, that you said is core to the model. I put, as soon as you start talking, I put the mantra that I always think of when I'm, working with kids that I've learned from you in the model, which is what you mentioned, that if you want to see a behavior again, give it your attention. So I think that's a good summary.
Yeah.
Well, Debbie, this was, even though I have been trained in the model and know it, I still learned so much, both from your research perspective, from the scaling up perspective, and even more deeply about the model itself. So I really appreciate your partnership, this beautiful model that you developed in partnership with communities. And we're so glad to be part of the CHIP community ourselves.
Thank you. And I appreciate you so much.
Thank you. So I'd like to pass the mic. In addition to having a wonderful lecture, we also take a couple minutes to celebrate people that really are advocates for young children and families in the community. Bree, if you want to show the slide.
Sure.
So I mentioned in the beginning of our talk that Dr. Moderessi was the medical director and had the vision for the center. But this could not be done without two incredible people. One I mentioned earlier, Carol Norris-Shortle, but also I want to just take a minute to remember Alma Truckley. She was our business manager. I had the great fortune to learn from her when I stepped into the center in 2005. And, it really takes a village. It takes all kinds of talent and perspectives to really collectively fulfill the mission of the Center for Infant Study. And so each year we honor that spirit that Alma brought to the work. And this, we're going to have two awardees today. I'm going to pass it on to Bree and to name and talk about the two Alma Truckley Award winners for this year for excellence in advocating for the mental health needs of children and their families.
Thank you, Kay. So glad to see everybody again. And we are so honored to have Dr. Gross with us. And our two awardees are close colleagues of Dr. Gross, of which she is both named already. So we can, we're glad that she can be with us and kind of share this honor with them. So I'm going to pass the mic on to Shanique. Shanique's going to present our first awardee, and then I'll announce our second awardee. Shanique.
Hi, everyone. I'm Shanique Rogers Henry. I'm a mental health consultant with the CIS team. I'm happy to be here. And I would like to just, and excuse my camera for being off. I'm traveling. My son just got an award, an honors award at college. So I'm leaving from the Eastern Shore now. But it is my honor and privilege to present this year's Alma Award to Kimberly Crew. When it comes to the Judy Center and working with families, Ms. Crew always goes above and beyond, sometimes so much that we have to remind her that she can't possibly meet the request of every family, but she definitely would if she could. Ms. Crew understands the importance of how building relationships with the families are a critical part in the success of children, birth to 5. That's why she's very intentional with the partners she chooses to be part of the Judy Center. Hartford Heights Judy Center is always one of the top highest performing Judy centers in Baltimore. And that can be credited to the amount of effort and dedication to the families that Ms. Crew has. So again, I would like to say congratulations to Ms. Crew, and thank you for all that you do.
Thank you, everyone.
Congratulations.
Oh my God.
Congratulations, Miss Crow.
Thank you.
Glad to see you.
Congrats, Miss Crew. Thank you, everyone. I literally text Shanique. I said, I'm going to kill you. I had no idea this was coming. No idea. Thank you so much. I'm honored and blessed to have someone like Shanique to work with our families in the mental health capacity. She's not only an awesome CHIP presenter, but she's just an advocate for our families and our children. There's nothing she won't do that I ask of her. We've been together now for 4 years. I don't know what I would do without her. Shanique is the one that gets the parents. Well, it's a team effort, but we usually do CHIP in the fall, and the parents, they come for all 12 sessions of CHIP, and that's usually how we get our core group. They keep coming back. And so those parents that have set goals for themselves and their children, they're the ones that we take and we case manage, and usually by the end of the year, they're all better off. And so, oh, look at these little notes. So I'm just
I'll have that for you when we get back to.
Oh my God, I'm gonna get you. I'm gonna get you. I'm gonna get you. And
Well,
she was insistent that I join this Zoom on my spring break, so but I wouldn't miss it. Oh my God, thank you all so much. Thank you, Bree and Kay, for being patient with me in Baltimore City Public Schools. But it's worth all the effort. And
wonderful. Thank you, Miss Crew. Kay's having some audio difficulties, so I know she's sending her congratulations and thank you as well. So in true Miss Crew fashion, and she has kind of set me up for my great honor to introduce our second awardee, and in sort of our continuing talking about our Chicago parent champions. Our second awardee for this year is, let me get there, Shanique Rogers. So congratulations, Shanique. We felt this two-part and sort of, our champions together who worked so hard to keep our parent programs going and active in the communities. I've had the great pleasure to work with Shanique since she came on board here. She was one of my first supervisees as a therapist here. She came on with us in 2014. She's a true champion in advocating for mental health. She even let me know just yesterday that she's looking towards advancing her career even further, which I am excited to support her with. And there's so much more I can say about all the work that she's done for the clinic and supporting our interns in early Head Starts, and just me as a person. She's just always been just so stable. She's humble, and she's just, I can come to her with my kid issues who are significantly younger than hers and doing similar things that her son was doing. So we've worked together for a long time. So this doesn't capture near the things that I was shared with in terms of some of the language and comments that we asked from many of her colleagues, but these are some of the beautiful ones that came out: caring, gracious, just a great listener, always knowing community resources, and amazing. I have asked one of our very close colleagues who sent me something last night that just kind of summed it up just so incredibly beautifully, in addition to these other things. So Ola, if you wouldn't mind sharing your words to Shanique to kind of close us out, I would appreciate it. I think I saw your name on here.
Of course, I'm here. First of all, congratulations to both awardees. Thank you very much for all that you do. A big congratulations to you, Shanique. You're an exceptional social worker, and your dedication to our families is truly inspiring. I've seen firsthand how dedicated and compassionate you are in your work, and your ability to connect with families and provide support and resources is truly remarkable. And I believe that it's a testament to your skills and expertise in this field. Your families, NCIS families, are very fortunate to have you by their side. And I also feel lucky, I'm pretty sure all of our other colleagues feel lucky to have you as a colleague. And it's been an honor to work alongside with you, alongside such a wonderful woman. And I know that you'll continue to make a positive impact on the lives of those that you encounter. Well done, and congratulations again.
Thank you so much, Ola.
Wow, thank you so much. This is like totally unexpected. I saw like my mom's name on here, my sister. I'm like, what are you doing on here? But thank you. I really don't know what to say, but thank you for just allowing me to be part of this team for so many years. I really, truly love it. I didn't know that when I first started working with the birth to 5 population that I would necessarily like it, because I was used to working with middle school and high school, but I absolutely love it. I love working with the parents and the families and just watching them grow and continue, especially like doing Chicago parenting. I tell everybody in every group that when I started, I think my son was maybe 3rd or 4th grade, and I've used the skills for him throughout. I would come home and practice on him, and he would, give me thumbs up or thumbs down, or tell me I was crazy or whatever. But one thing he said to me recently is that he feels so much love inside of him, and that's the one thing that I wanted for him. So thank you again, and I am truly surprised and honored. Thank you.
Well, thank you both so much. We know this was a challenging week to get you together, and I had to put Shanique to work on Kim's award to make sure she could join us. So, and Kim contributed to Shanique's as well. So we're glad that they could both be with us, even from afar and on spring break. And I think there's lots of comments in the chat that I can't really get to, but that Kay's still having trouble with her audio, I think.
I can talk now, but for some
Okay.
reason I can't get my camera back on, but
Okay.
I'm so proud to be part of this team and so excited. And we love it when we can surprise somebody. So way to go, Miss Crew. And Shanique, really fun to see your joy, in getting this award, and to hear the impact that it's made for Hartford Heights and the families there. And Shanique's on her way to honor her son, and so for her to share with us a story about how it helped her as a parent is just beautiful. So we appreciate everyone. We appreciate Dr. Gross for her work, friendship, her research, just everything that's really helped our team move forward with our mission. So couldn't have been a more perfect union today. Both the speaker and the awardees that really are the example of how this model shows up in the community and works for families. So couldn't have scripted it all better. So
Amazing. Perfect.
And special thanks to Dr. Edwards and her support for child parents, for CHIP, and that, having the chance to be part of the multi-site study and to do what Dr. Gross really talked about, which is kind of finding ways to stick to its core, but make it person-centered as well. So we appreciate that opportunity too. All right. Well, if anyone would like to stay on for an update on where we are at the center, before COVID time, we would have all been together, and we'd be hanging out, having a bit of a advisory board meeting. but we still want to take at least the opportunity to answer questions and to give any updates. And we hope that you will mark your calendar for next year in person. The last Thursday of April, and I'm sorry, I can't quite pull up. It's either the 25th or the 26th, but if you stay in contact with us, and Bree will be putting it out on our constant contact. We have Linda Gilkerson, who's going to be our guest speaker, and we really are going to have like a big day celebration as well. So we will be back in person, having a chance to share a meal together, share stories. So keep us in mind for late next April. All right, so we know that some of you will sign off, and we appreciate you being with us today. And those of you that want to stay on to ask Bree and I some questions about the center, and also hear about some of our updates, we love to have you. And if Dave and Andre are on, if there's any way they could help me with my video.
Okay, I wonder if you log on and off, if you come back to the meeting, sometimes that's the best fix.
I did do that, and that's how I got my audio back. But I'll do it one more time, Bree.
Okay.
Okay.
Okay. Well, we'll give Kay a few minutes. So if you want to grab, a drink or snack until we get back, I'm going to try and make my screen work so that we actually have the presentation rather than the PowerPoint. It's just not letting me switch screens here. Which screen do you see? Nancy or somebody, his video is on.
We see the Alma Truckley Award slide.
Okay, not the notes.
Actually, yes.
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 The notes are on you.
Yes.
Okay, thank you. There we go. Okay, so we did all this. There's Kim again. Shanique. All right, so we're here. This looks like the right place. We'll give Kay a few more minutes to come on. Thanks so much for hanging on with us. I sort of see Kay, and now I don't see her coming off mute. Well, I'll go ahead and get us started so we don't run over too much time. I'm sure Kay will be with us shortly, and I'll do, I know most of this, but I'll call some in if I need you, Carol and Nancy. So as most of you are probably aware, our leadership has mostly stayed the same over the past year. Dr. Edwards is our division and center director. She did just put something in the chat. She's traveling, so she is with us listening in. Kay continues to be our executive director, keeping us well funded and progressing forward in our work. I do most of the clinical directing and programming. Carol North-Shortle is still with us as faculty, assistant clinical professor, and Dr. Gerard came on with us, and I'm not sure, it's been within the last year. She's our professor and doing a lot of our training and psychological testing services, which we're so glad to have on board, and moving kids through testing pretty quickly from our close referral sources. Oh, I see Carol. She's not Ola, but under that name.
Nope.
I'm
gonna just
go with it.
into her spot.
All right. Go ahead, Kay. Take it away. Oops. Sorry.
Well, I think all of you know our mission, and we've really stayed very steady over 41 years. So we are very privileged to both do the work and to teach the work in a very deep way, and to be part of all kinds of quality improvement and research projects that advance the work. So. I guess we just wanted to take a minute, to reflect on the pandemic together. I mean, it really is staggering, and the impact on child development, and really emphasizes the urgency of this work, and also really the forward thinking of folks like Dr. Moderessi and Carol Norris-Shortle to really have kind of planted these seeds 41 years ago. Who would know that we've lived through a pandemic and the enormous mental health impact for adults and children, but particularly for our little kids. Researchers have found developmental dips in 600 children in a study, ages 3 months to 3 years, in cognitive performance, language, and motor skills during the pandemic. So we know the impact of developmental dips and delays, are going to be carried forward. So we're going to have to really have a preventative approach, like Dr. Gross was talking about. And that, as parents, the mental health concerns and burdens and impact have really hit parents hard. And as Dr. Gross said in her talk, we can't really take care of children without taking care of the parents. So programs like a Chicago Parent Program could be an incredibly important tool during these next couple years to help us with our recovery. And we see this for our education colleagues, it's showing up in school readidness data, showing that a 7-point decrease in kindergarten readiness. Only 25% of Baltimore City kindergartners and 40% of Maryland kindergartners are demonstrating readiness. And that's a significant backpedaling from all the progress that had been made in early care and education in places like Judy centers. So we have a lot of work to do. So we've held steady, and we have actually advanced during the pandemic, which was pretty remarkable. We kept our clinic thriving. As Bree will tell you, we have a wait list that she tries to manage very carefully. So we're accepting referrals, and really pretty early on, by July 2020, we were back, and kind of at first it was 25% of the people, and then quickly 50%, and then quickly 75% of the families were coming back in person. Our Healthy Steps specialists and our pediatric colleagues are really the heroes of the story. They were in person throughout and helping kids get to their well child visits. We know from pandemic research that lack of access to those kinds of services are really problematic across the 2-year period, but our colleagues were really amazing in getting kids in for their vaccines and their well child visits. We do a lot of work with our state partners, in particular, through our Center of Excellence in advancing the workforce. And then we have 2 federal grants. One is ending, and we'll talk a little bit about that, related to working with families that are impacted by the opioid crisis. And then our National Child Traumatic Stress Network grant that helped us bring the second Healthy Step site to the state. Next slide. So we continue to have a multi-revenue, approach. So we do collect clinical revenue. So the majority of our patients are insured through Medicaid or children's, health insurance, but we do also we are paneled with commercial insurances as well. And we have contracts that allow us to do the work in the community with early care and education through the Maryland Family Network and the Baltimore City Judy Center that Ms. Crew leads. We have a couple grants through the state. our behavioral health administration, Kaya's unit, led, and our particular domain is early childhood, led by Delisa Worthy. So we have a Center of Excellence grant that we're in the third year of a 5-year grant. And then we also had some funding through the state opioid response to really bring parent groups to families impacted by the opioid crisis. And I think Dr. Gross's talk was, very relevant for that work. And then our 2 federal grants through SAMHSA and the Department of Justice, which we're really ending that one now. We're in a no cost extension year. So just kind of had a chance to finish up some of the work, and we'll have some reports to share with you and some kind of report outs about some of the things that we've learned there. And then our wonderful foundation partners, the Krieger Fund and the Arnie Richmond Family Fund, has really helped us advance some of our Healthy Steps work. We do collect some fees for training, but mostly grant funded. And we have a wonderful new staff member this year, Sarah Rappin. She's here, I'm not sure, but we welcome her. And she had been one of our wonderful social work interns from our campus colleagues at the University of Maryland School of Social Work. So we're very glad to have her stay on. We continue, kind of a core part of our mission is training that next generation. So we continue to have 7 child psychiatry fellows. This year we have 3 University of Maryland School of Social Work, advanced social work interns that Shanique is the supervisor, and many colleagues have a role in supporting their training. We have a Johns Hopkins counseling student this year and a Morgan undergraduate student. And then we have medical, there's a special program that pediatrics runs, both for people that are interested and maybe medical students that are interested in becoming psychiatrists, and also a special ACE program. So the medical students can take an elective to learn more about adverse childhood experiences, and they start that rotation with our team. And we also work closely with our nursing colleagues, both to do some cross training, but also to have some students have some practicum experience with us. And then under our wonderful Dr. Gerard, we have psychology externs for the first time that I've been here, from Howard University and Catholic University. Dr. Gerard, do you want to talk about the psychology program and the psychology evaluations?
Sure, and I apologize. I have a sick kid at home, so you may hear some background noise. So since I started here about a year and a half ago, one of the things that I really wanted to focus on is providing psychological evaluations for our young kiddos so that they can have access to early intervention services as soon as possible. And as I'm sure you all know, Medicaid patients tend to have a harder time finding places that'll accept their insurance. So there are very long wait lists. So since I have been here at University of Maryland, we have received referrals for 117 children that are under the age of 6. And so far we've completed 62 of those evaluations, with the rest in the works. And just want to highlight our referral sources, a lot of which are on the call here now. So through CIS, our Healthy Steps specialists do a wonderful job of sending children super early to us for evaluation. Our Early Head Start programs, our BHIP telepsychiatry access program that'll provide evaluations to families that are in more rural parts of the state and may not have access to evaluations. And then of course, Judy Centers and our local pediatricians. So trying to make a big impact on getting these kids in as soon as possible. And we seem to be continuing to grow.
Thank you. Bree, you want to talk about the remarkable CARF achievements and
Sure. I think it was last year after the Taghi lecture that we did achieve our third 3-year CARF accreditation. And just this week, if Nancy's still on, she'll be glad to hear we got our conformance sticker. So we've conformed for the next year for all the things that we need to. So we're really proud of that accreditation and continue with that. We continue with consultation and intervention in various places throughout the city, as we've talked a lot about. Our VOCA grant has allowed us to get into places like Chrysalis House, both the Park Heights and Crownsville locations, in addition to Marion House, Family Recovery Program, and Dayspring. We've done some work with them with using with VOCA funds. That's gotten us to help families really where they are in those programs, rather than moms necessarily having to come to the clinic for services. And then, we provide some technical assistance, training with Frederick Safe Babies Court and Little Flowers Early Childhood Development Center here in West Baltimore. So some of our consultation highlights that Shanique is really the champion of, I would say. We continue with Maryland Family Network in 10 Baltimore City Early Head Start centers. And these just kind of highlight the things that we're most proud of doing. MSW intern training has been really integral in the work in these consultation sites, and they get a lot of they just learn a lot about what early childhood mental health, really is and where it starts, and get to do some of the Chicago Parent Program work with Shanique in the schools and get a sense of what it's like to run these groups. And a lot of the work, particularly in early Head Starts, is a lot around with the adults around crises that might be coming up. So we do a lot of staff office hours and crisis support and training in some of our models, including FAN. Let's see, and then Antonia and I both do some child care resource center reflective supervision through some of our COE funding and other funding, and continue with Carol to do some fan work and doing lots of training around that, both level 1 and level 2. Those of you familiar with FAN, if not, we're thrilled to talk about that as if questions are there. Facilitated attuned interactions, and certainly provider workshops. We still are close partners with the Baltimore City YMCA. Still reaches out for us to do some provider and family workshops on occasion that we do with them. So this is where we're doing a lot of work continuously for our consultation.
And if you're interested in the FAN, stick around for next year, because that'll be the focus of next year's Taghi Moderessi Memorial Lecture. So we did finish our 11th cohort of our certificate program. So this has been really an incredible journey. So we trained about 400 people in the state, and work with many colleagues and experts to launch that certificate program. So that's kind of core to still what we do. Very happy to have Dr. Gerard join us this year. That was really wonderful experience. Gosh. So as Bree said, we over 200 folks trained in the FAN, 70 providers in child parent psychotherapy. And through some grants, we were able to fund people getting trained in attachment vitamins, which is another parent, it's more of a parent education model to help parents with information about the impact of trauma and social emotional development. And then Shanique is also our lead on parent cafes, and that is like the FAN, kind of our 2 engagement portals, to really build relationships with communities, and they're really more focused on strengthening families and resilience and peer-to-peer support. So we're happy to be part of that network as well. And we're becoming the trainers internally for attachment regulation competency across our child service line. And we're going to be working with Delisa Worthy and the national team at FAN to train more state trainers. So Isn't you, Bree?
Sorry, having trouble with mute. So within the past year, we're proud to have some accomplishments and recognition that we've received through our partner with the YMCA. We were awarded the Healthy Living Award at their annual Martin Luther King Jr. Memorial Breakfast. Chrysalis House recognized us at their 15th anniversary event as one of their partners. Shanique, continues to be a rising star. She participated in a pretty selective fellowship with the University of Maryland, Baltimore here on campus, and got to advance some of her community work and just finished that up within the last year. Rebecca Selman is our other Healthy Steps clinician at Maryland at Midtown, and she's participating currently as a Healthy Steps ambassador through 0 to 3. And then we also have 2 submissions at the World Association of Infant Mental Health, where Carol and Kay will be in a month, I think, right?
In July.
July, sorry. I'm moving ahead. So those are kind of our big exciting things for the year. If you don't already know, we are very social. Please follow us on Facebook and Twitter. And we're also on the National School Mental Health, where we have lots of COVID resources that continue to be relevant, I would say, that we reference quite a bit with schools and things like that. So look out for those as well. So I'll let Kay talk about our Healthy Steps initiatives.
So this has been a long time coming, but it really is very relevant to the story that Debbie told today about, sustainability of models. So both funders and communities don't want to see just a lot of programs dropped in and then fade away. Really thinking about from the beginning, how can a really valuable, and in this case, preventive model, which are hard to fund, as she mentioned, get launched and spread and sustained. And so through lots of collaborative partnerships and learning together, and some very important funding from the Arnie Richmond Foundation, we have worked closely with Melissa Rock at the Maryland Family Network and Maryland Medicaid and 0 to 3 Healthy Steps National Office to problem solve. And now it's actually part of our state plan, our Medicaid state plan, a way to bill for Healthy Steps. So in Maryland, we're the first state in the country to have this enhanced well child visit code for any Maryland Healthy Steps site. So right now we have 2 Healthy Steps sites that are allowed to, use this code. And it adds an additional $15 to every well child visit and follow-up visit. And so we're hoping that will really, help to pay for the salary support of the Healthy Steps specialist. This is a population-based health initiative. So it's Medicaid is giving, some of the support and going to give technical assistance and support to programs that, are able to get the funding to get trained in Healthy Steps and bring on a Healthy Steps specialist. So there are, from what we know from a recent technical assistance call, Kaiser Permanente is going to roll out some Healthy Steps sites, and we're hoping some other colleagues will as well. So hopefully we're also putting in some grants, and hopefully some of them will come to fruition. So I think once we get kind of a critical mass of Healthy Steps sites, that is also can become a statewide sustainability prevention program. So we're very proud of that. Dr. Edwards has worked tirelessly on this from the beginning, and me by her side. And I don't know if Melissa Rock is here, but she's been an incredible champion and policy person, expert to work with. So this actually just started in January. So Ola, I'm going to switch over, talk about our community aspect of Healthy Steps through our community health worker.
All right. Hi, everyone. So our Healthy Steps team, we focus a lot on community outreach and just having community events. So right here is one of our newsletters that we had focusing on food resources, focusing on picky eating, and just letting our families know that we are there for them, giving them information, giving them resources, allowing them to know that our resources are available by connecting them to either food banks, either food drives, whatever that could look like, but also having Rebecca and Sarah on site, talking a lot about tips for picky eaters for little kids and how exactly can they sort that out. Probably won't have enough time to do the whole BITP, but so we've also have something within our Healthy Steps that we call our BITP project. So we realized a problem within our membership, within our collaboration with infant and toddlers, noticing that families are unable to schedule and continue their evaluation process with infant and toddlers. Just also seeing that there's a limited education of what exactly infant and toddlers looks like, and just bias within the community and stigmas among the medical community of people thinking that if my child is referred to this service, is this going to be on their record? Therefore, I don't want to refer them to that, and just highlighting the importance of early intervention. I think probably. So our solution to that was really implementing a referral information packet for our families. So really walking with them step by step, educating them exactly what should you be expecting after evaluation, what does the evaluation process look like, how long could you possibly be receiving services from. So really the hand holding and the one-on-one of care coordination really. We then implemented an extra contact information form. So we want to have mom's number, we want to have dad's number, anyone that's basically interacting with a little kiddo. And our follow-up process looks like this. So we would contact the families 5 days, 15 days, 30 days, 45 days after the referral, just calling them and just making sure that, hey, have you heard from infant and toddlers? If not, what's going on? We ensure that we encourage families to contact infant and toddlers themselves. So we always want to empower them and just helping them take control of the situation. So monthly, I meet with a social worker from infant and toddlers and just checking on families that we work with, sending her a list of names, going through them, understanding who their care coordination is. Are they being evaluated? If not, can they get evaluated as soon as possible? And just fixing whatever problems could possibly occur.
Thank you, Ola. And I know we're coming up on our time, so Bree, maybe we'll just we'll close down the slides if you don't mind. And we will be having a chance to talk about our work with families impacted by the opioid crisis. Ola, Bree, and I are scheduling kind of a report out about that. So if you'd like to learn more about that, that'll go out, and you can definitely join us on that day. So, any questions or
Just a comment, Kay. I hear and am aware of a lot of different things that you guys are doing, and and it's been nice this year as we've collaborated on some grants across town, which is always really great. But I'm always overwhelmed with when it's all sort of laid out there to see how much you guys are doing and how much work you do for the city, in the city, and for young kids. And it's just, it's really just affirming and wonderful. And I can't tell you enough how grateful I am for, our partnership and all of the stuff that you guys are doing. It's phenomenal, phenomenal.
Oh, thank you, Joyce. That feels really nice to hear. And yeah, it's a wonderful team to be a part of. I feel very privileged myself. Yeah, I think we try really hard to walk the walk, to do the work, to teach the work, to learn about the work, advance the work. But it's a lot of balls to keep in the air. And we can't do it alone. So that's why we need all of you. All right. Well, thank you for celebrating with us today. Particularly celebrating our 2 new awardees. So next year, we're going to try to get all the awardees to come, and we'll really be able to meet in person and take a little more time to celebrate all the accomplishments of the center and our colleagues. So it was a wonderful day, and we really appreciate Debbie's support, guidance, scholarship, wonderful model. So, and friendship. So thank you, everybody.
Thank you, Kay. I feel so fortunate to know you. Thank you, all of you.
We do too. Right back at you. And if anyone has a question, or, we have a couple more minutes, but Bree and I will just be here in case anyone wants to ask us anything. Thanks to Lisa. I see her hands clapping.